anemia and hypertension in this patient. Also, patient is having low BP and increased heart rate. So there's a possibility of hypovolemic shock. Otherwise, there is possibility of acute kidney injury and hepatic encephalopathy also.
Okay. What is your differential diagnosis?
My differential diagnosis would be portal hypertension leading to bleeding varices. There can be bleeding peptic ulcer, Beer-Haave syndrome, and also Mallory Weiss-Tier.
How does alcohol cause cirrhosis?
Um, Alcohol in itself is toxic because it causes cell injury by releasing reactive oxygen species and cytokines. Also, it causes changes in the lipid metabolism, and also it decreases the transport of lipoproteins out of the cells.
So, uh, the reactive oxygen species and the cytokines form a specific compound. Can you name the compound?
Trioxynitrite.
Pyroxynitrate. All right. So, how the alcohol, like the pyroxynitrate, is mutagenic?
Uh, can you repeat the question?
Okay. I ask you first. The reactive oxygen species and cytokines combine together, they form a specific compound. You tell me the name of the
Yes,
compound,
sir.
the pyroxynitrate. Now, can you tell me more about the pyroxynitrate?
Sir, I'll come back to this question later.
Okay, just remember, okay, the pyroxynitrate
Yes.
causes the destruction of the DNA of the growing cell, which means there will be having some mutagenic
DNA.
effect. Ultimately, there will be a formation of the cirrhosis of the liver. Remember this, okay? Now, tell me, what is the pathogenesis of the portal hypertension in chronic alcoholism?
In chronic alcoholism, the portal hypertension causes cirrhosis, which is characterized by cell damage, fibrosis, and nodule formation. And because of the nodule formation and fibrosis, it will obstruct the portal venous return, and hence portal hypertension will develop.
What is the normal pressure of the portal vein?
So I'll come back to this later.
Okay, just remember the normal pressure of the portal vein is 5 to 10 mmHg, okay? And the shunting occurs at 10 to 12 mmHg, and more than 12 mmHg, it will lead to portal hypertension. Remember this, okay?
So shunting occurs at 10.
Yeah, the shunting occurs at 10 to 12 mmHg.
Okay, sir.
All right. Now, tell me the triad of the portal hypertension.
The,
The
there is
triad.
hypoalbuminemia, triad of portal.
Okay. So
So
the
hypo,
triad of the portal hypertension is ascites, splenomegaly, and varices, correct?
yes, sir.
So
Yes.
they will ask you why splenomegaly. You will answer him. The splenic
The
vein receive inferior mesenteric vein, superior mesenteric vein,
Congested
and spleen.
splenic vein.
Yeah, go ahead, Dr. Prabhat. Can you answer this question? Why there is splenomegaly?
Yes, sir. As there is portal hypertension and obstruction due to fibrosis, there is congestion of blood in splenic vein, which drains to portal veins. So that's why splenomegaly is occurs.
Yeah, so the increased portal pressure causes the backflow of blood that will lead to ascites, splenomegaly, and varices. Remember, they will ask you how this ascites, splenomegaly, and varices occur, okay? So we'll answer him. The splenic vein receives the inferior mesenteric vein. The superior mesenteric vein and splenic vein combine together and they form the portal vein. So if there is increased portal pressure, that will cause the backflow of blood that will lead to ascites, splenomegaly, and varices. Why the patient is confused? Dr. Savelin.
because of the hepatic encephalopathy.
Yeah. So, what will be the blood picture finding?
In this patient, there will be increased MCV, megaloblastic anemia. Also, there will be liver enzymes will increase like serum, OT, PT, and GGT. And also, there will be low platelets because the Alcohol causing a direct effect on the bone marrow of the patient.
So toxic effect of the alcohol on bone marrow. Very good. Now tell me, what is the mechanism of ascites?
Ascites occur because of the retention of salt and water, because there is increased antidiuretic hormone levels. Also, there is increased flow of hepatic and splenic lymph, and there is hypoalbuminemia, which will cause more fluid accumulation.
Very good. Tell me, what are the hepatic changes as a consequence of the excessive alcohol consumption?
It starts with reversible changes like fatty changes, then steatohepatitis occurs along with the liver cell damage, and then it proceeds to the irreversible changes like cirrhosis and ultimately, finally, to the hepatocellular carcinoma.
Which varices do you usually bleed?
Lower esophageal varices.
Very good. Tell me the sides of the portosystemic anastomosis. The three common
The
sides,
sites
okay?
of yes, sir. The three common sites are lower esophagus, upper anal canal, and umbilical.
Now, in the lower esophagus, what is the portal in the systemic?
Uh, Portal. Portal is the branches of the left gastric veins, that is esophageal branches with the systemic azygous vein. And in upper canal, we have superior rectal vein with the middle and inferior rectal veins. And in umbilical, we have ligamentum teres with the superior or inferior epigastric vein.
Very good. Tell me how the alcohol is metabolized by the liver.
Alcohol causes catalase reactions, and no, alcohol undergoes catalase reactions, and hence also there are microsomal oxidizing enzymes and alcohol dehydrogenase. All of them will metabolize alcohol to a acetic acid.
Very good. Tell me the cause of confusion in this patient.
Hepatic encephalopathy.
Tell me the management of this patient.
I'll manage this patient by the care of critical surgical patient protocol by following MTT approach. I'll start with the high flow oxygen to this patient. We'll monitor the vitals strictly, arrange an ITU bed, and will establish an IV line and take up blood samples for full, full, full blood count, liver function test, renal function test, cross match, and group and save. And also, I'll arrange for other blood products like FFP, platelets, and fresh blood transfusion. I also consider central line insertion for the monitoring of central venous pressure and urine output monitoring. Otherwise, if the patient is actively bleeding, I'll consider for control of bleeding, which can be done by the Minnesota tube causing tamponade. Also, I can consider for endoscopic banding or sclerotherapy. And if not control, I'll go for urgent endoscopy by causing endoscopic band ligation.
Okay, tell me, you mentioned this endoscopic bending. Can you tell me more about it? Like how many bends per session?
6 to 7 bands, not more than 6 to 7 bands per session.
Okay, tell me about the sclerotherapy. What solution you will use in sclerotherapy?
I'll come back to this later.
All right. So, what is the cause of thrombocytopenia in this case?
Because of the destruction of the bone marrow by the toxins released from the alcohol, there is decreased hematopoiesis leading to pancytopenia. And
Okay.
also there is DICs and hemodilution.
And hypersplenism, correct?
Hypertension, yes.
Now tell me, what is the indication of platelet transfusion?
As the patient is actively bleeding and also DIC has set in, so we would like to transfuse platelets in this patient.
If the patient is actively bleeding, if the platelet count is less than 50,000, okay, in case of the if the prevention of the spontaneous bleeding, the threshold is less than 1000, okay, and also as a part of
Yes.
massive blood transfusion protocol. We will come back to the management of esophageal varices, okay. Now tell me,
Yes.
what are the patient is having macrocytic anemia. What could be the cause?
It is a nutritional cause, vitamin B12 deficiency.
Okay. How vitamin B12 deficiency causes macrocytic anemia?
Between B12 causes DNA synthesis. So when there is a deficiency, the DNA synthesis is inhibited. That is, the cell cycle is inhibited at the growth stage. So it will lead to it will there will be no division, but the growth will be continuing, which will cause increase in the size of the cells, resulting in the macrocytosis.
What is the surgical treatment option?
The surgical treatment options are TIPS, splenorenal shunting. We can also go for esophageal transection and or the orthotopic liver transplantation.
Tell me, can you define the tips for me?
It is transjugular intrahepatic photosystemic shunt.
And what area you will connect with this shunt?
I'll connect the hepatic vein with the intrahepatic branches of the portal vein.
Okay. Uh, Tell me, if the patient is going for the liver transplant, what you will tell the family?
I'll advise the family about the alcohol abstinence before the transplant, and if the cause is hepatic failure due to alcohol, he needs to stop it strictly so that to proceed for the transplantation. And the alcohol abstinence should be from 6 months to 1 year at least.
And you will counsel the family regarding the patient condition, proposed treatment options, okay, and the outcome of the treatment and lifestyle modification. Now tell me about the sensitive Lechimor tube.
Sir, can you please repeat sensitive?
Yeah, can you tell me about the Sengstaken Lechimor tube? Minnesota tube.
Saxton Blackmore.
Yeah.
Okay, okay, yes, sir. Sir, it is a double balloon tube used for the tamponade. It has ports for the gastric aspiration, esophageal ballooning, and also for the gastric suction. Also, there is a modification in which esophageal suction port is also attached, which is known as Minnesota tube. But in case we don't have a esophageal port for esophageal suction, we can go for NG tubing also.
Now tell me the indication of the Minnesota tube.
The indications of the Minnesota tube are when there is a life-threatening variceal bleed, and yes, sir,
If there is no response to medical
that
therapy, which include endoscopy,
okay, okay.
hemostasis, and vasoconstrictor therapy, and when endoscopy or hemostasis and vasoconstrictor therapy is not available. Now, tell me the techniques of the esophageal uh, Lechimor tube placement.
Okay. So for the placement, we need to position the patient and elevate the head end to 45 degree. And I will coat the balloon with the lubricant jelly and also coat the patient's pharynx with the topical anesthetics. I'll pass the tube from the nostril till the 50 centimeters of the tubing mark. And after the gastric balloon is positioned in the stomach, I'll inflate the gastric balloon to 500 ml of air and then will clamp it. For the esophageal inflammation, balloon inflammation, I will use the sphygmomanometer to 30 to 40 millimeters of mercury and then will clamp the port. So once if the bleeding, and also I will consider for the suction and the suctioning ports also for both the gastric and esophageal. If esophageal is not available, I will consider for nasogastric tube suctioning. So once the bleeding is controlled, I'll keep on reducing the esophageal balloon pressure by 5 mm every 3 hours. And if once the bleeding is completely stopped, I'll keep the tube for 1 day till 24 hours. And during this 24 hours, I will deflate the esophageal balloon for 5 minutes every 6 hourly to prevent the necrosis of the patient.
All right, very good.
Esophageal.
Now, about the management of the esophageal varices, that's how you will answer the question. Okay, you mentioned all those things, but remember, first of all, I will treat this patient according to the care of critically ill surgical patient protocol. Active resuscitation involved the fluid or blood. I will use two whole blood through the IV cannula, and I will activate the massive transfusion protocol. Remember, the full blood count,
Yes,
FFPs,
sir.
and platelets by the ratio of 1:1:1. I'll monitor the outcome hourly basis, and then I investigate the patient by full blood count, by urine electrolyte level, arterial blood gases level. Okay, I'll for the control of bleeding, I'll use the endoscopic bending, which is the gold standard, and 6 bands per session. Sclerotherapy, I'll use the 100% ethanol amine oleate. Okay, and we can give it the paravaricial, intravaricial, or combined method. Okay, then the medication like vasopressors, octreotide, and Minnesota tube. Now, the surgical treatment, including the tips, the staple esophageal resection, and liver transplant. You will answer the management like this, okay? All right.
Yes, sir.
That's it. We finished with the esophageal varices. Let me check it if there is anything else. Yeah, that's it.